Hello everyone, this is Dr. Ismail and today we are going to study about shock and its management from Bailey and Love. So we are going to study the definition of shock, types of shock, various clinical features of shock, management of shock and endpoint of resuscitation in the shock. So shock is one of the most common words we are hearing in the surgery, either in the trauma or in the perioperative workup. So every surgeon or every clinician should have basic knowledge and management of shock. So we are going to start the shock. So what is this shock? So what is the definition of shock? So shock is a systemic state of inadequate tissue perfusion leading to our anaerobic metabolism and impaired cellular respiration. So basically whenever there is shock, there is a decrease in the tissue perfusion. So whenever there is a decrease in the tissue perfusion, body's aerobic metabolism will shift to the anaerobic metabolism, leading to the hamper in the cellular respiration, and anaerobic metabolism will happen and there is a formation of lactic acidosis. So remember friend, shock is one of the major cause of morbidity and mortality in surgical patients. So coming to, there are some pathophysiological changes which are happening at our cellular level, at our microvascular level and at the systemic level. So what happens at cellular level? So whenever there is a decrease in tissue perfusion, so there is a decrease in oxygen supply to the tissues. So whenever there is a decrease in oxygen supply to the tissues, anaerobic metabolism will happen and there is a formation of end product of anaerobic metabolism. One is the lactic acidosis. So whenever there is an anaerobic metabolism happen, there is a formation of lactic acidosis. There are various transporters present at the cell membrane such as sodium potassium ATPase pumps. So there are dysfunctioning in this pump, leading to dysfunction in the transport, and there is a accumulation of fluid inside the cell, and also there is a dismembrane of the cell membrane. So there is a influx of calcium from outside to inside the cells, and this leads to releasing of lysosomal enzymes inside the cells. So whenever there are releasing of the lysosomal enzymes inside the cell, they are damaging to the other cellular particles and cellular substance, leading to the cell death as the end product. So whenever this happens, there are multiple cellular death will happen, leading to necrosis, or if there is a plant, there is a apoptosis. Though this happens at the cellular level. So what happens at the microvascular level? So at the microvascular level, whenever there is a shock, it leads to formation of our endothelial cell injury. So whenever there is an endothelial cell injury, there is a exposure of subendothelial basement membrane. So this subendothelial basement membrane exposure, leading to adhesion of multiple particles, multiple macrophages or multiple neutrophils at the subendothelial base membrane, and activation of coagulation cascade throughout the cell will happen. So whenever there is a activation of coagulation cascade and also sludging of the blood and decreased perfusion because of our microvascular thrombi, so this will happen entire circulation, and this lead to formation of disseminated intravascular coagulation in severe shock, and if happens at the multiple level, this leads to worsening of tissue hypoxia and multiple organ failure syndrome. So this happens at the microvascular level. So what happens at the systemic level? Remember friend, shock is a state of sympathetic system hyperactivation and leads to tachycardia and peripheral severe vasoconstriction, leading to reduced tissue perfusion. But except in the distributive shock, where we'll be having bradycardia and vasodilation and hypotension. So this we seen in the distributive shock. For example of distributive shock is our septic shock. And whenever there is a severe vasoconstriction, there happens progressive organ dysfunction. Suppose there is a severe vasoconstriction in brain, there is a altered sensorium and coma will happen. Whenever same happens with the kidney, there is oliguria and there is AKI sets in. Whenever it happens with our lungs, there is a acute respiratory distress syndrome, leading to increase in the minute ventilation. So whenever there is increased minute ventilation or increase in respiratory drive, there is a carbon dioxide wash out from the respiration, leading to compensatory respiratory alkalosis. So also there is a myocardial depression. So whenever this happens at 2 or more than two organs, there is a MODS, and this leads to irreversible shock and ultimately death will happen. So now we are going to see there are various types of shock. So first one is the hypovolemic shock. So hypovolemic shock is caused by decrease in the intravascular circulating volume, resulting in decrease in venous return, decrease in the cardiac output, and inadequate tissue perfusion. So in hypovolemic shock there is a decrease in the intravascular volume, but our cardiac pump is activating properly. Causes are either it could be due to hemorrhagic and non-hemorrhagic. So hemorrhagic is the most common cause. So hemorrhage, it could be either due to trauma, or it could be due to any operative surgery, or due to any gastrointestinal bleeding such as esophageal varices, and also due to any kind of ruptured abdominal aortic aneurysm. So non-hemorrhagic causes such as dehydration related to persistent vomiting, persistent diarrhea in cases of acute obstruction, paralytic ileus, or any kind of gastroenteritis, or excessive urinary loss, which is seen in cases of patient on diuretics treatment, or patient with the diabetes mellitus, diabetes insipidus, and also there are third space losses which are happening in the burns patient, and also in cases of acute pancreatitis, any cases of peritonitis, and severe sepsis. So these are the causes of non-hemorrhagic shock. And also coming to our second shock is the cardiogenic shock. As we have discussed, in the hypovolemic shock there is a decrease in the intravascular volume, but cardiac pump is activating normally. But in the cardiogenic shock, heart is not working properly, but intravascular volume is our normal. So cardiogenic shock is defined by the failure of heart to pump sufficient blood to meet the metabolic demands of the tissue, resulting in reduced cardiac output despite adequate intravascular volume. So this is our cardiogenic shock. So cardiogenic shock, it could be due to primary cardiac causes which is related to cardiac tissue, such as acute myocardial infarction, which is the most common cause, and seconds are cardiac arrhythmias related to any valvular heart diseases, or any kind of blunt cardiac injury such as myocardial contusion, or any kind of cardiomyopathy, either could be dilated or restrictive, or suppose in the peripartum cardiomyopathy, alcoholic induced dilated cardiomyopathy. So these are the types of our cardiogenic shock related to heart per se. But there are other causes which are not related to heart, such as endotoxins. So endotoxins, what will happen in case of severe septic shock? So it leads to myocardial depression, and also if there are any myocarditis due to any autoimmune disorders. So these are the causes of cardiogenic shock. So coming to our distributive shock, this is the third category. Distributive shock is characterized by inadequate organ perfusion due to widespread peripheral vasodilation, resulting in decrease in systemic vascular resistance, hypotension, and maldistribution of blood flow. But remember, as in the other shock, there is a vasoconstriction and tachycardia. But in distributive type of shock, either it could be due to, for example, if there is any severe sepsis, so there happen due to endotoxemia, so instead of vasoconstriction there happens vasodilation. And suppose if the patient with the spinal cord injury, so spinal cord injury, because of decrease in our sympathetic outflow below the thoracolumbar junction, so there happens severe vasodilation. Suppose in the case of anaphylactic shock, because of releasing of anaphylactic substance and vasodilators such as histamine, nitric oxide, so there is a profound vasodilation happens, and patient will be having bradycardia and hypotension instead of tachycardia. So this is the type of our distributive shock. And there is increase in cardiac output which happens in all the shock. There are decrease in cardiac output, but in distributive shock there happens a increase in cardiac output in the initial stages. So example of these distributive shocks are, remember, one is our septic shock, anaphylactic shock, and neurogenic shock because of our spinal cord injury. So coming to our fourth category, that is a obstructive shock. In obstructive shock is our heart is working normally, but there is obstruction to the flow of the blood from the heart. So it could be either there are obstruction at the preload or obstruction at the afterload. So whenever there is a obstruction at the preload because of our cardiac tamponade, tension pneumothorax, or whenever there is a obstruction at the outflow because of our massive pulmonary embolism happening at the pulmonary trunk. So this is the type of obstructive shock which leads to obstruction to the either pre-filling or post-filling from the heart. So coming to endocrine shock, so endocrine shock is a form of circulatory failure caused by severe endocrine disorders. So it results from a combination of hypovolemic, cardiogenic, distributive shock mechanism, so leading to tissue perfusion. For example, if the patient is having adrenal insufficiency, so there are no any adrenal hormones are released in the body, so this leads to Addisonian crisis, and this is the most common endocrine causes of shock. And also, if patient is having severe hypothyroidism, so there are chances of myxedema, coma, or shock. And whenever there is a patient is having severe hyperthyroidism, so it leads to thyroid storm, and this leads to excessive hypersympathetic activity and leads to heart failure because of our severe hyperthyroidism, because thyroid hormone acts as a sympathomimetic. So if there are increase in thyroid hormone, sympathetic activity also increases more. So what happens at the clinical consequences of all this shock? Why we are studying these shocks in the details? Because whenever this shock is happening, initial stages of shocks are reversible, but once this reversible stage is over, there happens a unresistable or irreversible shock. So whenever there are unresistable or irreversible shock happens for prolonged duration, and its intensity also increases, the cellular injury which was reversible in the initial stage, now it becomes irreversible, and restoration of circulation cannot be possible, and this leads to our severe metabolic acidosis, refractory hypotension, not reacting to our any kind of inotropic support, and leads to progressive organ failure, and ultimate outcome of this irreversible shock is the death despite adequate resuscitation. So remember friend, if you want to treat the shock, your reversible stage or early stage is very much important, so that you should resuscitate the patient properly before patient landing up into the unresistable or irreversible stages of shock. So first is our unresistable stage. So next is our systemic inflammatory response syndrome because of consequence of shock. So whenever there is a shock happens in the body, so it leads to systemic inflammatory response syndrome by releasing multiple inflammatory mediators throughout the body. Either it could be because of endothelial cell injury, or either it because of tissue injury, or either because of it is microvascular injury happening at the multiple various aspects. So there is a profound releasing of systemic reactionary mediators throughout the cell, leads to activation of widely endothelial cell injury, disseminated intravascular coagulation, and capillary injury, predominantly mediated by interleukins TNF alpha, interleukin 1, and interleukin 6. So this persistent systemic inflammatory response syndrome progresses to sepsis, and it ultimately leads to multiple organ dysfunction syndrome. So this SIRS is clinically, we can label either it is a increase in the temperature, or decrease in the temperature, or increase in the heart rate, or sometimes there in the septic shock there happens a bradycardia, and also there happens a altered respiratory rate. So this happens in the our systemic inflammatory response syndrome, which criteria will be seeing in the next chapter. So also, whenever suppose if there is a kind of shock in the, and you are not resuscitating the patient in the early stage, and you are going to resuscitate patient in the irreversible stage, so there happens ischemic reperfusion injury. So whenever you restore the blood and restore the circulation in the irreversible stage, so whenever there are reperfusion happens, it generates multiple reactive oxygen species such as free radicals, and this free radicals activation or free radical generation leads to neutrophil activation and further endothelial cell injury and further cellular damage. So this stimulates the positive feedback mechanism, and there happens the reperfusion injury, and this leads to our more profound stages of shock. So whenever we want to reduce this reperfusion injury, remember we have to treat the patient as soon as possible in the reversible stage, so that we reduce the rate and duration of our hypoperfusion to the cells. So next happens our multiple organ dysfunction syndrome. So what is the definition of this multiple organ dysfunction syndrome? So whenever there is a progressive dysfunction of our or failure of two or more organ system, remember two or more organ system, this is the MCQ question, leading to severe kind of shock, and hemostasis cannot be maintained without any emergency intervention. So common organs affected, as we know, lungs leading to ARDS, CNS leading to coma state, heart, kidney, and multiple systemic inflammation also there is also happens a DIC, and various organs throughout the body will affected. So remember friend, this multiple organ dysfunction syndrome, it carries a mortality of our approximately 60%. So this is also one of the important MCQ. And treatment of multiple organ dysfunction syndrome is only by supportive management. So there are no definitive line of management. Supportive management, what is supportive management? If there is a failing heart, you have to support the heart by inotropes. If there is a failing lung, we have to do the intubation and mechanical ventilation to the patient, so that there are only supportive management. So to prevent the multiple organ dysfunction syndrome, prevention is always better than cure. Hence, recognition of early stages of shock and treatment of shock is very much important to prevent the consequences of shock. So, compensated shock is the early stage of shock in which tissue hypoperfusion present, but compensatory mechanism maintain the blood pressure and vital organs to the tissues. So there is a term called as occult hypoperfusion. Perfusion, occult hypoperfusion means there is a less perfusion to the tissues are happening, but our compensatory mechanism are keeping our blood pressure normal, our urine output are normal, and our cardiorespiratory status happen. But remember friends, if this hypoperfusion or occult hypoperfusion happens more than 12 hours, it is associated with our higher mortality and increased infection rate and increased incidence of multiple organ dysfunction syndrome. So just don't think that your patients are vitals are normal and patient is not in the patient is bleeding somewhere internally, and patient is because of compensatory mechanism maintaining vitals, and you just think that your shock treatment is over. Always go and think about end point of resuscitation, which we are going to in the next session. So if you miss this occult hypoperfusion, there are 12 times of chances, and also if there are increases more than 12 hours in the occult hypoperfusion, there are increased chances of MODS, increased chances of cellular injury, and it leads to increased infection rate also. So remember friends, up to 15% of blood loss volume happening, which is the type 1 stage of shock, your vital parameters will be within normal limits. Once the percentage of blood loss more than 15% will increase, so your vital parameters start decreasing. Remember friends, don't rely only on blood pressure, because blood pressure will fall after 30 to 40% of your blood volume decreases. That is your stage 3 of shock. So you are thinking our patient BP is normal and our patient not in the shock, or we have resuscitated the patient, but remember blood pressure will drop only at the once your blood volume decreases by 30 to 40%. So this happens at the class 3 stages of shock. So basically the hemorrhage, what is the pathophysiology and trauma-induced coagulopathy. So initial principle of management of any kind of trauma hemorrhage, the principle is the arrest the source of bleeding. So arrest the source of bleeding either due to pressure, by either using slip or any kind of suture or any kind of endovascular intervention. So first arrest the source of bleeding, and simultaneously aggressive resuscitation is very much important. So both the things should go by hands on. And after that, once this hemorrhage control is done, there is a one more term called as acute traumatic coagulopathy. So what is this acute traumatic coagulopathy? Suppose there is a severe tissue trauma and hypo plus also patient is having hypovolemic shock which you are not resuscitated properly, it leads to the acute traumatic coagulopathy. So what happens in the acute traumatic coagulopathy? Remember friends, it is characterized by systemic hyperfibrinolysis, and there are low fibrinogen levels and platelet dysfunction. This leads to impaired thrombi formation and also ineffective clot formation. So there is a acute traumatic coagulopathy. It is characterized by our hyperfibrinolytic state. There is no any clot formation and there are platelet dysfunction. This leads to DIC kind of state and patient will start bleeding like anything. So this acute traumatic coagulopathy occurs in 25% of our trauma patient, and it increases mortality by 4 times compared to our normal trauma patient. So whenever there is a severe tissue trauma such as in crush injury associated with hypovolemic shock, remember there is a term called as acute traumatic coagulopathy. It leads to more bleeding in the patient. So there are different types of hemorrhage. One is our revealed or external hemorrhage which we can see, and there is also concealed or internal hemorrhage which we can't see, which happens in the body cavities. Also there are different types of hemorrhage. What is the primary hemorrhage, which is asked most time in the Viva question: what is the primary hemorrhage? So primary hemorrhage occurs immediately either due to trauma or due to surgery. So that is a simple. So this management requires your pressure application, ligation, suturing, or vascular repair. What happens in the reactionary hemorrhage? So reactionary hemorrhage occurs within 24 hours after injury. Suppose if you operated any patient and the patient, because of your spinal level anesthesia, your BP will be on the lower side. So once the blood pressure becomes normal, if there is any clot is you are stopping the blood, and due to increasing blood pressure, this dislodgement of clot will happen and patient will start bleeding, which we'll see most commonly in the operated case of our thyroidectomy patients. So if there is any dislodgement of clot, or if there is a restoration of normal blood pressure, or if there is a relieving of any kind of vasospasm, or you are not tied the suture properly, so this leads to slippage of ligature, and also there is a inadequate hemostasis. So these are the causes of our reactionary hemorrhage. So these are the many times asked our MCQ questions also and Viva questions. So these are the repeated multiple questions. And what happens in the secondary hemorrhage? So secondary hemorrhage happens in the day 7 or day 14 post-operatively. So basically this happened because of sloughing of or erosion of blood vessel, either due to because of your infection. And suppose you have operated any abdominal surgery, you have kept the drain. So because of your continuous drain effect, or because of your continuous drain pressure, there is a pressure necrosis of the vessel because of drain, leading to bleeding, which happens in the because of a drain or tube, and sometimes because of your malignancy, or sometimes because of infection, tissue necrosis will happen. This leads to secondary hemorrhage at the day 7 or day 14. So remember friends, so whenever you are going to treat the trauma patient or any kind of shock patient, so there are three categories of one patient. One patients are responder, in which after doing adequate resuscitation, patient will show improvement in the vital parameters. And also there are transient responders. Transient responder patient will show response only for few minutes, and again their vital parameters will drop back. And there are non-responders. So there are non-responders, they are not showing any kind of response to your resuscitation, because in the non-responders your rate of bleeding or hemorrhage is happening in the patient is more than your rate of administration or rate of resuscitation. Suppose your patient is losing 1 liter of blood, and you are going to infuse the patient only 250 ml or 300 ml of blood, the patient will not respond. So these are the non-responders. So non-responders and transient responder patient, you should keep in the check, and you should monitor the patient properly, or else your patient will go into the irreversible stages of shock. So our ATLS classification is there in the degree of hemorrhages. So one is our class 1 hemorrhage, that is less than 15%, and class 2 is 15 to 30%, class 3 is 30 to 40%, and class 4 is more than 40% of your blood volume. Remember friends, blood pressure will drop only in the class 3 stage, that is 30 to 40% will happen in the class 3 stage. So remember, hemoglobin is a poor indicator of degree of our acute hemorrhage, because it represents only concentration, not the absolute amount of blood volume loss. So because it remembers, or it mimic, or it reflects only your absolute concentration of your RBC, not the amount of blood loss. So never always rely on your hemoglobin. And also in acute hemorrhage, hemoglobin may be normal initially and falls only after redistribution or extracellular disease. Suppose if you have seen any kind of blunt trauma injury, blunt trauma to the abdomen, initial hemoglobin will be normal. So once you starting resuscitation by patient by using crystalloids, so there happens a hemodilution. And also if patient is losing blood, so you have to monitor serial hemoglobin. Monitoring is important rather than one single spot of monitoring of hemoglobin. So hemorrhagic resuscitation, there is a term called as damage control resuscitation. So what are the principle of this damage control resuscitation? So first is identify and control the source of hemorrhage immediately. So without controlling the source of hemorrhage immediately, do not go for resuscitation aggressively. Suppose if the patient is having peripheral external injuries or peripheral crush injury, and it is bleeding from femoral artery, popliteal artery, first go and tie the vessel, so that after that only go for resuscitation. Patient is bleeding peripherally and you are infusing the fluids or infusing blood, that is the no value to this kind of management. So damage control resuscitation tells, first identify and control the source of hemorrhage immediately, then go for simultaneously resuscitation. So what are the goals of damage control resuscitation? Rapid hemorrhage control is the first stage Next is the permissive hypotension. So friends, remember, permissive hypotension is very much important concept. So you have to keep the blood pressure of the patient on the lower side. Lower side means should be less than 90 beats 90 mm of Hg. So whenever there is an increase in blood pressure, again the patient will start bleeding more. So till your hemorrhage control is under check, you have to keep the blood pressure of the patient lesser on the less than 90 by 90 mm of Hg. And also there is a avoid dilutional coagulopathy by infusing excess of crystalloid fluids to the patient, and as soon as possible use the initial blood product by your resuscitation. And also treat existing any coagulation disorder to the patient by using plasma, platelets, fibrinogen, and use the tranexamic acid or injection pause as soon as possible in the trauma patients. So these are all our damage control resuscitation. One is the rapid hemorrhage control, next one is permissive hypertension, third one is avoid dilutional coagulopathy, use balanced blood products initially, treat existing coagulation defect, and use tranexamic acid as soon as possible within the trauma patients. So the control of bleeding, restoration of tissue perfusion, these prevent the lethal triad of injuries such as hypothermia, acidosis, and coagulopathy, which leads to morts and death in the patients. So damage control surgery principles are: arrest hemorrhage as soon as possible, control sepsis, protect from further injury, nothing else. No definitive management, only damage control surgery, resuscitation to the patient. So shock resuscitation. Resuscitation should not be delayed to establish a definitive diagnosis of the cause of shock. So treat all the shock by thinking hypovolemic shock and start resuscitation immediately, and don't wait for your diagnosis or to find out the cause of shock. So if there is any uncertainty regarding the type of shock, treat all patients having hypovolemic shock until unless proven otherwise. So perform rapid clinical assessment to identify the likely causes of shock. So what are the different types of fluid therapies in the shock? Initial resuscitation with crystalloids followed by inotropic support if hypotension persists after adequate volume replacement. So start crystalloids initially. After infusing the crystalloids, if the patient is not showing improving the parameters, start arranging blood product as soon as possible. Until that, start inotropic support to the patient. No inotropic support before your crystalloids or fluid therapy. IV access and fluid administration by securing two short wide bore cannulas which are size of 14 to 16 gauge for rapid fluid administration. Don't go for any kind of central line insertion to the patient, because these central lines are thin and longer channels which are required for the post stabilization for monitoring the fluid therapy, not in the initial resuscitation phase. So remember friend, always use 14 or 16 gauge cannula and don't go and run behind the central line in the trauma patients. So blood products replacement is required as soon as possible in the hemorrhagic shock patient. Fluids to be avoided: avoid hypertonic solutions which has dextrose containing solutions, because these are the poor plasma volume expanders and should not be used in the treatment of shock except in diabetes insipidus and patient with cirrhosis, because these patients are already in the volume overload state. In that case you can use the dextrose solutions, but not in the all the types of shock. So vasopressor and inotropic support in the shock, so not indicated as a first line therapy. First line therapy is either crystalloids or your blood products. Once the blood PP is not maintaining, then start your inotropic support. So early use without correcting hypovolemia with inotropic agents can cause severe vasoconstriction, reduced tissue and organ perfusion, and decrease in the coronary perfusion. Again, it aggravates the positive feedback mechanism, leads to multiple organ dysfunction syndrome. So what are the various different types of our inotropic supports? In distributive or septic shock, norepinephrine or noradrenaline is initial agent of choice. Once your patient is not maintaining vitals after starting noradrenaline, then you can start vasopressin if the response is not adequate. In distributive shock selected situation, phenylephrine, example, rarely if the patient is having tachyarrhythmias, when you are started the epinephrine or norepinephrine, then you can start the phenylephrine. And also If the patient in the cardiogenic shock, dobutamine is the inotropic of the choice because it is having predominantly cardiac effect. So remember friend, in the distributive or septic shock, go and start with your norepinephrine. If the patient is not showing any response with norepinephrine, then you can go with the vasopressin. But in some types of shock, if the patient is having tachyarrhythmias because of your norepinephrine or noradrenaline, then you can switch over the phenylephrine. And in the cardiogenic shock with low ejection fraction, dobutamine is the agent of choice. So once you resuscitate the patient, the monitoring of the patient is also very much important, whether you are resuscitated properly or not. So cardiovascular monitoring is first parameter in cardiovascular monitoring is our central venous pressure, that is a CVP. So there is no normal single value of the CVP for the shocked patient. So this is the line given in the belly. There is a no normal reference range for the shocked patient because CVP changes with each patient with each different types of shock. So CVP also it reflects poor indicator of our left ventricular end diastolic volume, that is your preload, and ventricular compliances change rapidly during the stages of shock, stages of resuscitation. So CVP will differ based on your various resuscitation and various stages of shock. So there is a no single parameter of CVP value in the shocked patients. So don't trend in the CVP after fluid challenge is more useful than a isolated reading. Suppose you have given the fluids to the patient and CVP increases by 2 to 3 centimeter and CVP again falls back. So this is showing non-responding or transient responder. Suppose if you have resuscitated the patient properly and CVP is persistently rising more than 2 to 3 centimeter, it means you have resuscitated the patient properly and now you have to keep only the patient on maintenance fluid instead of aggressive resuscitation. So this is the importance of CVP, and CVP monitoring should be ideal and sequential monitoring, hourly or depends on the patient need in the ICU care setup. No single reading is important in the CVP monitor. So always keep in the mind, CVP monitoring should be checked with blood pressure monitoring, urine output, lactate and clinical examination. Also remember friend, whenever you kept the patient on mechanical ventilation, because of your increase in positive expiratory end pressure, that is PEEP, your CVP value also increases. So always minus 2 to 3 centimeter your mechanical ventilation of CVP, mechanical ventilation from the your measured CVP, that gives your exact CVP. So whenever the patient is a mechanical ventilation, it gives false result of increase in the CVP. So there are different various aspects of monitoring of cardiac monitoring apart from CVP. Invasive monitoring such as pulmonary artery catheter monitor, which is measuring now, which are measuring lesser in the nowadays, and also there are non-invasive types of such as Doppler ultrasound, pulse waveforms, and indicator dilution techniques. These are most commonly measured in the intensive setups. And when to monitor these patients and why can we monitor all the patient? Remember friends, which patient we should monitor aggressively? Patient failed to respond first line of therapy after doing adequate fluid resuscitation. You have resuscitated the patient properly but patient is not responding. And if you are suspecting cardiogenic shock, and also if there is any evidence of myocardial dysfunction is present in your patient and you have started the inotropes and any kind of supports, you have to monitor these patient. And also your shock is persistent or your diagnosis is not sure what is happening with the patient, which kind of shock is this in this patient. So these are the patients which you should be monitored properly. So how to monitor patient? So systemic and organ perfusion monitoring in shock patient is by urine output. So urine output is the best bedside indicator of systemic organ perfusion and adequacy of resuscitation, and also it reflects the renal or perfusion. Normal urine output in adult patient is 0.5 ml per kg per hour, and in children it is more than 1 ml per kg per hour should be there for adequate resuscitation. But the urine output monitoring is having drawback that you are going to measure it hourly, not minute to minute variation, which is happening in our shock patients. So this is the drawback of measuring urine output. And also second one is the level of consciousness. We assume that once the patient is conscious normally and responding properly, and we assume that patient is cerebral perfusion is normal. But remember friend, till the last stage of shock, that is stage 3, more than 30 to 40% of blood volume loss, patient is maintained conscious or patient become little bit of drowsy. Once stage 3 of shock is over, patient will start becoming drowsier in the comatose stage. So till stage 3 patient may maintain the consciousness level. So don't only rely on our how the patient is responding to you. And there are other gastrointestinal and skeletal muscle perfusion markers. So there are no reliable clinical signs to directly assess the perfusion of gastrointestinal tract and or skeletal muscle. The best indicators are serum lactates, because these are the anaerobic metabolism products and which increase in the anaerobic metabolism in the cellular levels. And also if your lactate levels are not increasing, means it is showing that you are resuscitate the patient properly. And also there is a one more term called as mixed venous oxygen saturation. So what is this mixed venous oxygen saturation? Suppose you have transported 100 molecules to the cells. If your cells are taking 100% of oxygen by taking normal aerobic respiration, the oxygen which returns back to the cardiac tissues, it reflects your mixed venous oxygen saturation. Suppose if your patient is in a low system, mixed venous oxygen saturation indicates inadequate tissue oxygenation. So suppose normal mixed venous oxygen saturation, cells extract only 60 to 80% of transport oxygen and 20% of oxygen will come back to your heart. Suppose if their patient is in hypovolemic shock, what happens? The cells are in the more in the anaerobic metabolism and cells need more of the oxygen. So whenever you transport oxygen to the cells in the hypovolemic shock, what happens? These hungry cells will pick up more oxygen. So your mixed venous oxygen saturation, which is normal, is 60 to 80%. It decreases in cases of hypovolemic shock, that is 50 to only 60%. So this happens in hypovolemic cardiogenic shock. So when there is in the cases of septic shock, because of your profound vasodilation, there is happen of anaerobic metabolism. And also in the septic shock, because of impaired tissue oxygen extraction and there is a microvascular dysfunctioning happening in septic shock, the cells will not take up the oxygen properly. So mixed venous oxygen saturation increases, that is it is 70 to 80% value, but normally it is 60 to 70%, but in septic shock it is more than 70 to 80%. But if the septic shock is associated with underlying hypovolemia, the mixed venous oxygen saturation will decrease, that is less than 50%. So remember friend, if the hypovolemic shock, the mixed venous oxygen saturation will decreases. In the cases of septic shock, the mixed venous saturation is more than 70 to 80%, but hypovolemia plus septic shock, your mixed venous oxygen saturation also decreases. Only in the septic, preferably septic shock, mixed venous oxygen saturation will increases. So these are the various types of MCQ asked. In which condition mixed venous oxygen saturation increases, decreases, and what happens in the normal septic shock, what happens in normal septic shock with hypovolemic shock. So these are the various clinical parameters. So occult hypoperfusion we have discussed in the beginning also, and we are going to see some of our Bailey and Lowe images. So this is the table taken from the Bailey and Lowe, and it is showing various cardiovascular and metabolic characteristics of shock. Remember friend one thing, in all the suppose these are the hypovolemic, cardiogenic, obstructive and distributive type of shock. In the cardiac, in the all the shock except there are variation or some terms are changing in the distributive shock. Cardiac output decreases in all the shock except in the distributive shock. In distributive shock, cardiac output is the high in the initial stage. And also systemic vascular resistance is high in all the shocks, because there is a low cardiac output and there is a severe systemic vascular vasoconstriction, so that it will supply more blood to the heart. But in distributive shock there is a profound vasodilation, so systemic vascular resistance is low in the distributive shock. And also what happens in the mixed venous oxygen saturation? So mixed venous saturation is low in the all the shock except in the distributive shock, which is high, as we discussed in the beginning. And also what happens in the venous pressure? Venous pressure is the low in the hypovolemic shock because in decreasing intravascular volume, but in the cardiogenic and obstructive shock our venous pressure is high, and in distributive shock because of vasodilation our venous pressure is low. But venous pressure increases only in the two types of shock, that is in the cardiogenic and distributive shock. Why in the cardiogenic? Because our heart is not able to pump properly. And why in the obstructive shock? That the heart is not able to pump out of the blood from the heart. So in these only two conditions, venous pressure is more. Venous pressure is nothing but your central CVP pressure. CVP pressure increases in the our cardiogenic shock and our obstructive shock. And what happens in the base deficit? Remember, base deficit is always high in the all the shocks. So there is also there are also damaging there are also how to monitor the various systems are tables given in the Bailey and Lowe. So first is the systemic or organ perfusion measurement is by our normal base deficit, lactate, and also mixed venous oxygen saturation. This is the systemic perfusion measurement. And how to measure the organ perfusion such as muscle? So it is measured investigation by near infrared spectroscopy or tissue oxygen electrodes, or we can measure the by tissue oxygen electrode. And gut perfusion, how to measure this gut perfusion is by our sublingual capnometry or gut mucosal pH and also laser Doppler flowmetry. How to measure the perfusion of the kidney? We can measure by urine output, and there is no any other investigation is required. And how to measure the brain, that is conscious level, and also by using tissue oxygen electrode and by near infrared spectroscopy. So these are the monitors of organ or systemic perfusion. And also one more table is given from the Bailey and Lowe, that is damage control resuscitation and perfuse targeted resuscitation. So whenever in the patient with a trauma or any kind of injury, you are seeing the patient in the trauma, initially the management is by damage control resuscitation. First you have to recognize any patient is active bleeding from the periphery, stop the bleeding, and after stopping the bleeding by pressure application or suture, then give your fluid management test, fluid challenge test. If the patient is showing improvement in the vital parameters, then categorize the patient whether responders, transient responders, or non-responders. So based on that, you have to categorize the patient. And what are the this goal of this damage control resuscitation? The damage control resuscitation goal is the prioritize the coagulation function first and coronary perfusion second. So goals of these damage control surgery are resuscitation are: damage control surgery, do as much as required initially. Suppose if the patient is you are not able to arrest the bleeding in your minor OT, take the patient to the major OT. If the patient is having crush injury with femoral vessel bleeding, tie it. Don't go for any definitive management of orthopedic fracture or any kind of surgeries which are needed for definitive management, which we can do in the next setup once the patient is vitally stable. Next one is permissive hypertension. Keep the blood pressure check less than 90 mm of Hg. Balanced transfusion 1:1 RBC, RBC, platelets, and FAP should be required for transfusion. And also treat coagulopathy by using earlier tranexamic acid, platelets, or any kind of fibrinogen. In the damage control resuscitation, monitor with cardiovascular such as blood pressure and heart rate, and also electrolytes by calcium and potassium, and coagulation by prothrombin time, fibrinogen, and also rotem or TEG is also important. And after that, what is this TEG? This is the thromboelastography, which we have uploaded our one video specifically and separately. This thromboelastography, because our routine blood parameters give only reflects the coagulation at one setup, but this rotem or thromboelastography, it gives your minute to minute variation which is happening at the coagulation cascade, and based on that you can infuse the platelets or FAP or tranexamic acid to the patient. And also perfusion, how to assess the perfusion by taking serial ABG, base deficit, lactate, and temperature management of these patients. So these are the damage control resuscitation points. So once you are attained the hemostasis, so once you have kept the patient stable, next one is you have to prioritize the perfusion to the end organs or important organs. So second part is the perfusion targeted resuscitation. First part is damage control resuscitation, second part is the perfusion targeted resuscitation. So this goal is perfusion of the end organ. Adequate preload and afterload maintaining by preload fluids and afterload by cardiac pressures and inotropic agents you should be started in the perfusion targeted resuscitation, and you have to maintain the thromboprophylaxis also. This prioritize in the perfusion targeted resuscitation. So how to monitor this perfusion targeted resuscitation? By same cardiovascular, blood pressure, heart rate, and you have to monitor cardiac output and also systemic vascular resistance. Perfusion by base deficit, also by lactate and mixed venous oxygen saturation is important in the perfusion targeted resuscitation. And organ function, suppose if you want to maintain the organ perfusion to lungs, PaO2 by FiO2 ratio is important. Urine output monitoring is also important, and GCS perfusion, GCS monitoring is also important if you want to monitor the your CNS system. And abdominal compartment by intra-abdominal pressure. So these are the perfusion target resuscitation. So when you are seeing the trauma patient, divide in the two. First one is your damage control resuscitation. In damage control resuscitation, prioritize your arrest bleeding, prioritize the arrest bleeding, give the fluid challenge test, arrange the blood products, and if your patient is responding, transient responder, non-responder, classify into three different sections. And permissive hypertension, balanced transfusion products of 1:1:1 ratio of RBC, FFP, and your platelets, and treat the coagulation initially with your tranexamic acid. Once your patient is vitally stable, next management is your perfusion targeted resuscitation. So you want to, in this to perfuse only to your vital organs. So this is all the types of shocks, management of shock, various aspects of shock, and various some of the important points given in the Bailey, such as CVP is not a single parameter, and also how to monitor and what are the endpoints of resuscitation. So these are the some of the important aspects taken in the Bailey. And if you have any doubts, please go and read back again Bailey. And if you have any doubts, please contact us through our WhatsApp channel or Instagram channel on Every Surgeon. Thank you. Keep studying.